I have 3 CFers on my list for that day. My arms are jello. Do we give as good of a manual CPT as we could? Sometimes not. Sometimes I'm looking at my schedule going, I've got 7 minutes for you. Breathe, breathe, nebulizer, I've got 7 minutes. And I'm trying to beat on you during that time because I've got another 100 patients also, right? Especially when we're short-staffed and we're picking up for 2 people who did not call in but did not show. Huh, sounds familiar, doesn't it? Be on a night shift where there's 7 of you supposed to be there and only 3 show up. So, yeah, so you know you're scattering, you know you're running, you know you're doing this. We're not goofing off during the night. And then to have CPT. Now, is CPT appropriate for every patient? No. If the patient has had GERD, who in here has had GERD before? How many of you want it back? Put you in Trendelenburg and I've made a new friend who will not let me back in that room ever again. And so, you know, got to keep in mind what else is going on with this patient. Do they have high ICPs or do they have high blood pressure? Maybe this is not a good spot for them as well. And then think of the patient, is this going to be a good treatment to go home with? So think of some of your patients. So I have to think of my next door neighbor, Charles and Shuggy. Shuggy is maybe, if you stretch her, 5 foot tall. Charlie, he is 6'6". Would it be appropriate for Charles to do some CPT on Shuggy? His whole hand can cover her chest. Probably not the most appropriate therapy. And vice versa. Can she do a good job for him at home? Probably not. And the fact that they're 82 years old probably makes a difference too. So think about, is this something that my patient will be able to do going home as well? Because some of these treatments do go home with the patient, as we well know. I find CPT to be an awesome treatment in the children's hospital. So I have a PICU background as well. And I also am very controlling. So when we go into the hospital, not once do we look at a parent and say, hey, is it appropriate? Do you mind if I take your child to x-ray at 8:05? Would you prefer breakfast at 8 or 7:30? We don't ask them any of that, do we? We just walk in, do our thing. Excuse me, would the breathing treatment work for you at 8:15? That's not what we do. We take all control away from a very controlling mama. And she's got a sick baby, so she's now in sick baby controlling mode. The one thing that we can give back is CPT. Because is it going to hurt the child to get extra CPT? No, we can show them how that they can rock their baby and go to town. They can lay across their lap and go to town. Or as my 14-year-old will go, my chest hurts. Can I play my video game and you beat on me? Yes, yes. I love that. That's me and him time. I know I get more than that. But for a 14-year-old to ask to spend time, seriously. So can that be something that you can teach the parent and then you're getting extra therapy? So I find that to be a great time there for the parent. So the next devices are going to be the positive expiratory pressure devices and the oscillating positive expiratory pressure devices. At the top of the screen, we have the acapella, or excuse me, we have the flutter. Then we have the aerobica here. These two work with the patient being in an upright position. So they either have to sit up or stand up in an upright position. The next one is the acapella down here, also known as the pickle. And this one can be done with the patient being more reclined or even on their side to be able to use this device. Now, there is also the quake. I find this one interesting. So the majority of our patients who get these types of devices tend to be COPD patients who tend to be a little bit older. And now you're going to ask them to grab the blue handle and spin it as they exhale. Really? I'm not sure who thought of that, but they forgot about our patients. And then the bottom one is our smallest one, haha. It's called the lung flute, and I would say it's about 16 inches long. So it's a really convenient one to travel with and go places. So, but if we think about these devices, they're usually inexpensive. They are usually a first-line tool. Most of them are small, they're portable, they're inexpensive, but they are patient effort dependent. If your patient gives you poor effort, you're only getting poor therapy back. The other thing to keep in mind is that if your patient only has 53% of lung volume, you're only working 53% of their lung volume. So it's something that, is this the most appropriate one for the patient? I find that a lot of patients get this first, and if it works for them, great, it works. Just keep in mind that the best form of airway clearance therapy is the one that the patient will use. So I can tell you all the wonderful things about all of these, but the only one that's the best one is the one they use. So the next is intrapulmonary percussive ventilation, IPV. IPV uses pneumatic therapy, and it's 300 bursts of air per minute for 20 minutes. So roughly 6,000 bursts of air in a 20-minute period. The air gets behind the mucus and pushes it out, and it's meant to help open patchy atelectasis as well. The number one con is a sore chest. But if you did that to your chest 6,000 times or 3,000, 6,000, then your chest would be sore too. So that makes sense. It is a device that can go home with the patient. Next is our continuous positive expiratory pressure, continuous high frequency oscillation device. This is the Hill-Rom Metaneb system. It is hospital use only, and this is part CPAP, where it opens up the chest. It's part pneumatic therapy, where it's doing the taps on the chest, and then you can do a breathing treatment as well. So there's a lot going on, but there is therapy there. So it is a hospital use only device. I think I said that. Next is the acoustical percussor. This is made by Westmed Vibralung, and it uses sound waves anywhere from 5 to 1200 hertz, and those sound waves get behind the mucus and help motivate it forward. The key here with this acoustical percussor, or even our acoustical devices like and I didn't mention this one, the cornet or the lung flute, those are both acoustical. If you have dry secretions will not resonate sound. If it doesn't resonate sound, it's not moving the secretions. So this might not be the most appropriate device for a patient with dry secretions. So something to keep in mind. Next is mechanical in-exsulfation, or as so many of you know, cough assist. So this is where the purpose of the cough assist is intended to stimulate secretion clearing coughs. It can be used with a face mask, a mouthpiece, or an adapter. And the patient does have to be able to follow basic directions to be able to use this device. Next, we have the high-frequency chest compression. There are three main competitors in this category. There's the vest, the smart vest, and the encourage airway clearance system. So two of them work off of a sine wave. The sine wave works more like a piston, where it uses the air inside of the vest to create the thumping on the chest. The other one uses a triangle wave system, where it's an open system where air goes in and out of the vest at any given time, and produces more of a chopping system, more mimicking CPT. What we see with this is that there's more airflow at the mouth for the triangle wave versus the sine wave. More airflow at the mouth means more sputum being produced by the patient. We know that with the sine wave, it's a closed system operating like a mechanical diaphragm, that it starts with a higher base pressure in the vest than the triangle waveforms, and as the chest expands, the space between the chest and the vest decreases, resulting in increased pressure on the patient's chest. With the triangle waveform, the system's open to the atmosphere, and air in the vest is released into the atmosphere both in response to the user's breath and through cycling of the air pulse spikes produced by the system's air chopping system. In a study done by Dr. Warwick, who is the grandfather of airway clearance and of high-frequency chest compression, we see that he wanted to know, can HFCC work in CF patients? Now, looking back, we know the answer, but this is the first study to confirm a hypothesis that effective airway clearance can improve lung function. So what we look at is their percent predicted FEV1 prior to vest therapy, the start of vest therapy, where you can see that the majority of them have a declining percent predicted FEV1, and then after the start of vest therapy, they either maintained or increased their percent predicted of FEV1. If they were decreasing before, we've changed their quality of life to maintain or get better. And that's what we want with these patients. Now, a cystic fibrosis patient does fall underneath the category of bronchiectasis. They make up about 10 to 12% of our bronchiectatic patients. So if they can change their lung volume, can the other portion of our bronchiectasis patients change their outcomes? I would hope so. So what we have is roughly 24 million Americans who have impaired lung function, meaning COPD is underdiagnosed. How many of you agree with that? Yeah, a good number of you. Out of that 24 million, we have 12 million that do have diagnosed COPD. From there, we have roughly 7 million patients who are moderate to very severe COPD patients. Of that 7 million, roughly 4 million of them have diagnosable bronchiectasis. And only a little over 500,000 have been diagnosed with bronchiectasis. So we're missing a huge group of patients. So that's what we want to, think of on those, because they are just like our CFers. They have high mucus content, really sticky, and they've got to move it out. So how do we know how to diagnose these bronchiectatic patients? It requires a high-resolution CT. Now, our radiologists are wonderful at identifying tumors and what's going on in the lungs, and they're really good at describing the lungs. Now, not always do they describe bronchiectasis because it's not what they'll get sued over. If they miss a tumor, they get sued. So we might have to send back a CT and say, can you reread this for bronchiectasis? But in the report, things that we want to hear are, or not want to hear, but things that we will hear for bronchiectasis are tree and bud seen throughout. So you can see the branches of the tree, and then you see the dots. That's our buds, the tree and bud that we're looking for. Next, they'll say something like honeycombing or grape clustering seen. So there's some honeycombing there in the bottom right. You can kind of see where it looks more like a honeycomb, and up here at the top center, you can see where that looks more like grapes are clustered together. Do you guys see that? Okay. And next they'll say lack of tapering of the airway. That's airway remodeling, just in case. And what they're meaning, now, I will tell you, the markings that are on here are vascular. I need the slide to go this way, not this way. But through the vascular markings, which are also not tapered, you can see what I'm talking about, because they should be tapered as well. But do you see here where it's a chunk of airway? It's a chunk of airway. Should just be like, think of a tree outside. Closer to the trunk of the tree, they're bigger, and then they taper all the way out until they're really tiny towards the end, right? You're not going to find like a 3-inch tree limb out there at the end, are you? They're going to be tiny. And that's what you want. You want that tapering throughout the lung field. So those are going to be, if you're reading the radiology report, those will be phrases that you'll see that can make you go, wait a minute, this patient might have bronchiectasis. So high-frequency chest compression and bronchiectasis research. It shows that HFCC improves pulmonary function and quality of life, should be the principal option in airway clearance. Both CPT and HFCC showed a significant improvement in biochemical and functional respiratory tests, as well as quality of life compared to the control group. ACT results in improved pulmonary outcomes. We know it works. I can tell you airway clearance therapy works. How many of you already believed me before I even started today? It should be every one of you. But our problem comes into the fact of our patients. Our patients don't believe us, and we are not helping them. And that's more about what I believe in. So just before I hit this slide, let me tell you something about me. My dad is a 150-year pack lifer. 5 packs a day for 30 years. My 2 aunts who now live together are 200-plus pack lifers. They're my dad's sisters. And boy, is it fun over there. And so, I have heard everything that you possibly could have told somebody about airway clearance and about COPD and all of this because they informed me. So we have to match the airway clearance to the patient's activities of daily living. So how many of you know when I say a trumpet or a cornet, how many of you guys all know what I'm talking about? It's that purple one that's, okay. My dad was given one of those. And he was told, Mr. Short, you need to do this at 6 a.m. and 6 p.m. Okay, now the one thing that Dad has taken away from me is that he takes all of his meds, all of them, in a baggie with him to every visit. And then anything that they give him, whether it's a piece of paper or whatever, he shoves in that bag.